Welcome to today's webcast on lung cancer screening coverage in state Medicaid programs. Before we begin, as a reminder, at the bottom of your screen, there are multiple application widgets you can use. All of the boxes are resizable and movable, so feel free to move them around to get the most out of your desktop space. For the best viewing experience, we recommend using a wired internet connection and closing any programs or browser sessions running in the background that could cause issues. For the best audio quality, please make sure your computer speakers or headset are turned on and the volume is up so you can hear the presenters, and make sure the media player on your screen is enabled. If you have any technical difficulties during the webcast, please let us know via the Q&A box. If you have any questions during the webcast, you can submit them through the Q&A box. This webcast is being recorded and will be available tomorrow and can be accessed using the same link you used to register. And now we'll begin the webcast, and I'll turn it over to Erica Sword, National Assistant Vice President for Advocacy at the American Lung Association.
Thank you so much, and welcome everyone. We're so glad to have you on today's presentation on lung cancer screening coverage in state Medicaid programs. As you can see, we have a number of wonderful speakers for you today to walk through both the findings from a new report the Lung Association has released today, as well as to hear a wonderful lung cancer screening overview from Dr. Myrna Godoy at the MD Anderson Cancer Center. It's now my pleasure to introduce Deb Brown, the Chief Mission Officer of the American Lung Association. Prior to serving as Chief Mission Officer, Deb served as President and CEO of the Lung Association of the Mid-Atlantic until the Lung Association united into a single nationwide organization on July 1st of 2017, when she became the Executive Vice President for the region. Deb is a 37-year employee of the American Lung Association. She holds a BS degree in Public Health from Westchester University and an MS degree in Health Education from St. Joseph's University. She has been a certified health education specialist since 1993. Brown began her career as a health educator responsible for the development, implementation, and evaluation of adult and pediatric lung disease programs. Her past experiences have included working on advocacy issues in the areas of tobacco, asthma, school health, and healthcare. Deb has written curriculum and lesson plans for various health education programs and has developed and implemented training programs for school personnel throughout the Mid-Atlantic region. Deb?
Thank you, Erica, and welcome everyone. Lung cancer is the nation's leading cancer killer of both women and men, and it accounts for approximately 24% of cancer deaths. Only 16% of lung cancer cases are diagnosed early when the disease is most treatable. Low-dose CT screening among those at high risk for lung cancer reduces the lung cancer death rate by up to 20%. The number one strategic imperative of the American Lung Association is to defeat lung cancer, and reducing morbidity and mortality associated with this disease is among the Lung Association's key objectives. This project builds upon the many efforts of the American Lung Association on lung cancer screening and lung cancer more broadly. In 2014, the American Lung Association launched LungForce to increase awareness of lung cancer as the number one cancer killer of both women and men, educate and empower patients and healthcare providers, and to raise critical funds for lung cancer research. In 2017, the American Lung Association and the Ad Council launched Saved by the Scan, which is a campaign that aims to help raise awareness about lung cancer screening and encourage high-risk individuals to learn more and talk to their doctor to find out if lung cancer screening is right for them. In 2018, the American Lung Association partnered with the American Thoracic Society to create a first-of-its-kind implementation guide for lung cancer screening programs. Intended for community hospitals and healthcare systems, the guide is a pragmatic step-by-step plan to help design, implement, and conduct low-dose CT screening programs for lung cancer. Also in 2018, we released our first State of Lung Cancer report, which takes a closer look at the burden of lung cancer in each state across the country. The report provides information on 5 key indicators: early diagnosis, incidence, survival rate, screening centers, and surgical treatment. Finally, we have a number of additional resources and information about lung cancer available at lung.org/lungcancer. We're looking forward to continuing to work to defeat lung cancer through our new partnership with the University of Texas MD Anderson Cancer Center. The new data and resources we are releasing today will help public health and lung health organizations, state and local coalitions, and healthcare professionals work to improve coverage of lung cancer screening in state Medicaid programs. I am now going to turn back the program to Erica.
Thank you so much, Deb, and it's now my pleasure to introduce Dr. Godoy. Dr. Myrna C. Godoy is an associate professor at the Department of Diagnostic Radiology at the University of Texas MD Anderson Cancer Center and the clinical director of MD Anderson's Cancer Center Lung Cancer Screening Program. Following her radiology residency, Dr. Godoy completed a fellowship in thoracic imaging at the University of Sao Paulo in Brazil, a fellowship in thoracic and abdominal imaging at the University of British Columbia, and a research fellowship in thoracic imaging at the New York University. Her main current research interests focus on lung cancer screening and biomarker validation, shared decision-making and smoking cessation, imaging characterization of lung nodules for malignancy risk assessment, technological advances in computed tomography imaging, including dual energy computed tomography, iterative image reconstruction, and radiomix. We are so pleased to have Dr. Godoy on the line today as part of this presentation.
Hello, everyone. Thank you very much for having me. It's really a pleasure to be here today and to be able to speak a few words about lung cancer and screening. Lung cancer is the second most common cancer in men and women, and as you heard before, it is still the most common cause of cancer-related death in both men and women. As you can see from this image, it's responsible for 27% of the cancer deaths in men and 26% in women. It actually claims more lives than prostate and colon cancer combined in men and breast and colon cancer combined in women. The majority of the lung cancers are related to smoking, and smokers have greater than 20 to 30 times greater risk of developing lung cancer. And the problem is that when the diagnosis is made based on symptoms, the disease is usually already locally advanced or metastatic. And unfortunately, the prognosis is poor at that stage. You can see here the 5-year survival rate for patients with locally advanced disease is around 25%, and for those with metastatic disease, around 4%. But the survival can be much improved with early detection. For example, stage 1A disease would have a 5-year survival rate of 77%. So that's the goal of lung cancer screening, to do early detection and decrease lung cancer mortality. Several randomized clinical trials were designed to evaluate the use of low-dose CT for lung cancer screening, with the National Lung Screening Trial being probably the most important one. This was a huge trial. It involved over 50,000 patients, 33 participating sites, and it was truly a game changer because it was for the first time able to demonstrate a decrease in lung cancer mortality with low-dose CT screening. In this study, they compared the use of low-dose CT screening with screening with chest radiograph, and they were able to show 20% decrease in lung cancer mortality with low-dose CT screening. This was published in 2011, and now most recently, the Nelson trial, another large trial performed in Europe, presented their results and confirming the benefits of lung cancer screening. In this study, they compared low-dose CT screening in high-risk patients with the standard of care, which is to not do screening at all in Europe, and they were able to show that low-dose CT screening increases early detection, and they demonstrated a 26% reduction in lung cancer mortality for high-risk patients. The reduction was even higher in a small subset of women in this cohort. So that confirms the benefits of low-dose CT screening. And based on those results, the majority of the medical associations in the U.S. are now recommending low-dose CT screening for high-risk patients. The U.S. Preventive Services Task Force has given a Grade B recommendation for screening, and as a result, private insurance is now covering screening for this high-risk population. CMS is also reimbursing screening for this group of patients. But for us to really see the full benefits of lung cancer screening, it's very important for it to be performed in an organized, standardized way. The American College of Radiology has created a lung cancer screening center designation to assure that screening programs met high-quality standards. For a screening program to have these high-quality standards, they should focus in all the components of a lung cancer screening, starting with the education of all healthcare providers that are involved in lung cancer screening, as well as the population. And that includes shared decision-making so that the patients are empowered to assess if a screening is right for them. Another very important point is eligibility criteria. Lung cancer screening involves a small amount of radiation, and however, radiation is cumulative, so we want to make sure that we are screening patients that are really high risk for developing of lung cancer. There are other potential risks related to false positives, which may require additional imaging and the associated costs of that, as well as potential risks when intervention procedures are needed. So we want to make sure that we are screening the right population. Several organizations have established their eligibility criteria. They all mimic the NLST criteria, but are some minor variations. For instance, the task force includes patients that are asymptomatic, age 55 to 8 years. They have a history of smoking of at least 30 pack years, and they are either current smokers or former smokers that have quit within the last 15 years. CMS has similar eligibility criteria, as you can see here in the bottom, but an upper age limit of 77 years. Another important point is image acquisition that should be standardized, performed with multi-slice scanners, thin slice images, and with a radiation dose limit of 3 milligrams for the standard size patient. Structured reporting and nodule management is also extremely important so that we can facilitate communication and make sure that the findings are managed appropriately. I just want to illustrate how the LungREDS looks like. LungREDS is the lung imaging reporting and data system that most programs are using. I know this is too small to read, but just to illustrate how it looks like. Depending on the findings, the nodule type and nodule size, a specific category is given to the screening test, and each category will have a specific management recommendation based on the probability risk of malignancy. Let me just illustrate a case so you can understand that better. This patient, for example, had a negative screening, and then on the subsequent annual screening, we see a new left upper lobe nodule. This nodule measured 13 millimeters and was suspicious for malignancy. So this scan is a LungREDS 4B. Recommendation was to do a PET-CT, not only to evaluate the nodule, but to assess the possibility of metastatic disease in this patient that had a high suspicion for malignancy. You can see on the right the nodule is shining, it is metabolically active, and that increases our suspicion. So a biopsy was performed confirming a lung adenocarcinoma. This patient was cured with a left upper lobectomy. His history would be much different if we had to wait for this nodule in the left upper lobe to grow and become large enough to invade the chest wall and the pleura on the right, or to invade medially the mediastinum and become symptomatic, or perhaps to develop metastatic disease. At that point, his prognosis would be much worse, and the cost related to treatment would also increase significantly. So this is the benefit of lung cancer screening. And here's just another example. A patient, you can see here with the yellow arrow, a lesion in the right main bronchus. PET-CT was also performed, and this patient also had a positive node, and this patient was treated with neoadjuvant therapy and resection of the malignancy. This was a 4X, another high-risk classification for suspicious lesion. Another important component is the referral network. We need to make sure that we have appropriate management of the findings suspicious for cancer and also other potentially significant findings that we can see. Keep in mind that with the low-dose CT screening, we also see the lower neck, we see the mediastinum where the heart is, we see the upper abdomen. So we can find other possible neoplasms, vascular disease. All of those need to be addressed. And I also want to make a consideration about referral network. For those patients with positive findings that may need repeated imaging or even invasive procedure, it's very important to be aware that those invasive procedures should be conducted at a place with high-quality provider and facility. There are studies showing that the risks related to invasive procedures are more than twice when those are performed in community setting compared to the NLST. So those risk procedures should be performed with high-quality provider and facility. Just a few words also about smoking cessation. Lung cancer screening programs must be associated with smoke cessation counseling and opportunity for smoking cessation treatment. This is probably our main tool to fight lung cancer. You can see from this graphic the cumulative risk of developing lung cancer for patients that continue smoking. You can see this in red. And then for patients that stop smoking at different ages, with the dark blue being patients that stop at the age of 60 and light blue at 50, orange at 40, and so on. So patients that stop smoking can significantly decrease their risk of developing lung cancer, and the earlier they do that, the better. Data collection is also important so that we can do quality control and we can do future refinement on screening. CMS currently requires data collection and submission to a national registry, and we can use that data to improve how we perform lung cancer screening, and also for research. And in terms of research, there is a lot of interest in improving personalized risk assessment, and for that we can use blood biomarkers that are being investigated. We are also looking into better ways to characterize the detected lung nodules using, for example, artificial intelligence, as well as all the research related to treatment options. So in conclusion, lung cancer screening works. It's now covered by CMS and private insurance in high-risk patients. But for us to really achieve the full benefits of lung cancer screening, it should be universally available for all high-risk patients, and it should be performed in a manner to maximize effectiveness. Screening programs should be multidisciplinary and should be using state-of-the-art techniques, and invasive procedures should be performed at high-quality providers and facility. So with that, I want to thank you very much for the opportunity to be here.
Thank you so much, Dr. Godoy, and we're excited that you are able to stay on for questions as well. Just a reminder, as we do go along, if people do have questions, they can chat them in the Q&A box, and then we'll answer them at the end. It is now my pleasure to turn the program over to Emma Will, the American Lung Association's National Specialist for Health Research and Policy. Emma is one of the researchers and authors of this report we are releasing today. Emma?
Thanks so much, Erica. So as Dr. Godoy took us through a couple of different coverage guidelines for lung cancer screening, I just wanted to highlight how that affects coverage. Because the U.S. Preventive Services Task Force has given lung cancer screening for high-risk individuals a B grade, most private insurance plans are required to cover this service at no cost to patients. And then in February of 2015, Medicare began covering lung cancer screening for a very similar high-risk population with only a slightly different age range. The Affordable Care Act also required states to cover preventive services with an A or B grade for individuals, so this again falls into that category. For individuals newly enrolling in Medicaid through the ACA's coverage expansion to 138% of the federal poverty level. As a result, in the 37 states that have chosen to expand their Medicaid program under the ACA, adults in that expansion population who fit the USPSTF high-risk profile should also have coverage for lung cancer screening. However, states are not required to cover the screening for the standard Medicaid population, which leaves a potential gap in coverage. This gap in coverage of lung cancer screening for standard Medicaid enrollees is significant because a higher proportion of Medicaid beneficiaries currently smoke compared to individuals with private insurance. And the 5-year survival rate for lung cancer patients is also significantly lower for patients with Medicaid than for lung cancer patients with other insurance. With the support of the University of Texas MD Anderson Cancer Center, the Lung Association surveyed state Medicaid fee-for-service programs between December 2018 and January 2019 to assess current coverage of lung cancer screening in state Medicaid fee-for-service programs. Earlier today, we released a new issue brief with our findings. And if you click on the Resources tab, you should be able to download the issue brief and look over as we speak. We found that 31 Medicaid fee-for-service programs cover the lung cancer screening, 12 programs do not cover the screening, and 7 programs did not have information available. And I just want to call your attention to the fact that this analysis only looked at lung cancer screening coverage in Medicaid fee-for-service programs, not across all Medicaid managed care plans in states. For some background, fee-for-service Medicaid is the traditional model in which states pay providers directly for services, and the state essentially acts as the insurer in fee-for-service programs. In managed care, the state contracts with managed care organizations to deliver Medicaid health care to enrollees. So many managed care organizations follow the fee-for-service coverage of their state, but they may differ in their eligibility criteria, their prior authorization requirements, and other features of coverage policies. Conversely, in states that do not cover lung cancer screening through fee-for-service, the managed care plans of that state may still cover the service. And as you can see on the map, Tennessee is a separate color than the rest of the states, which is because Tennessee does not cover anyone through traditional fee-for-service Medicaid. All Tennessee Medicaid enrollees are enrolled in Medicaid managed care organizations. So because we only looked at fee-for-service, we do not have data for Tennessee. And overall, these findings are encouraging, but you can still see the gaps in coverage of the orange states. Our issue brief also looks at the guidelines different states follow, as well as whether states require prior authorization for screening. So of the 31 state Medicaid fee-for-service programs that do cover the screening, 13 follow the USPSTF criteria, 13 follow Medicare criteria, and 15 follow other criteria. Establishing clear eligibility criteria for lung cancer screening is important to ensure that only those who are at a high risk for lung cancer obtain the screenings. Recent research has shown that the screening is often inconsistent with evidence-based guidelines, with the number of individuals inappropriately screened for lung cancer actually exceeding the number screened according to the USPSTF criteria in 2015. Screening people who do not meet the high-risk criteria puts people at risk for false positives and unnecessary invasive procedures. Additionally, 13 states require prior authorization for screening, meaning that providers have to get prior approval from the Medicaid program before providing the screening. Research has shown that prior authorization requirements can delay patients' access to care and even lead some patients to abandon treatment. And in the case of lung cancer, when early detection is key, this is obviously a problem. And with that, I will turn it over to Hannah Green, who's our National Director of Health Policy.
Thank you, Emma. So we really hope that the coverage information that Emma just shared can be a really great resource for all of the different stakeholders on the call today to begin to identify where there may be gaps in coverage in your state or areas for improvement to ensure that those who meet the high-risk criteria are able to access screening without any financial or administrative barriers that could limit their access to care. But we know that that information is only a starting point. And so another really exciting piece of our partnership with MD Anderson Cancer Center was to launch this state lung cancer screening coverage toolkit that I'm going to talk with you about today. The toolkit has resources for public health and lung health organizations, state and local coalitions, and healthcare professionals to use in their work to educate decision makers about gaps in coverage and work to improve lung cancer screening coverage in their state. All the resources that we're going to talk about today are available at lung.org/lung-cancer-coverage, as you can see on this slide. And as Emma mentioned earlier, if you look at the resources tab for today's webinar, we also have a link to the toolkit there as well if you'd like to poke around that and follow along as we go through some of the different resources that are available with you right now. Obviously, the first thing in the toolkit is the issue brief that Emma just talked about, and you can take a closer look at the map and the coverage chart and get a closer look at the data for your state. Again, this is a really great starting point to see where improvements can be made in your state, whether that be there's no coverage in the fee-for-service program to begin with, where the eligibility criteria might not be following evidence-based guidelines, there are prior authorization barriers to address, etc. In a few days, we'll have the recording of today's webinar, so you can take another listen if there's things that you missed today, and also you can share this with other colleagues who you think might be interested in this issue to give them a kind of 101 on lung cancer screening coverage and the new resources that we're launching. We have a number of new fact sheets and additional education materials for stakeholders, and I'm going to go through those in a little bit more detail in just a moment. And then finally, we have a portal for patient stories. Patient stories are a really powerful tool to educate people about the life-changing impact of lung cancer screening and really highlight, as Dr. Godoy went through earlier, how important early detection can be for a patient's prognosis. So this campaign and this project that we're working on today will build off the Saved by the Scan campaign that Deb Brown mentioned earlier that the Lung Association has been working on for the past couple of years, and continue to add to that collection of patient stories about the importance of lung cancer screening and the life-saving benefits so that we can use those as really powerful tools to help stakeholders understand why improving coverage is so important. So a couple of other resources in the toolkit that I wanted to highlight. First, we have an open letter from Dr. Rizzo, the Chief Medical Officer of the American Lung Association, and Dr. Haymock, the Chair of Thoracic and Head and Neck Medical Oncology for the University of Texas MD Anderson Cancer Center. This letter really highlights how important lung cancer screening coverage is, particularly in the Medicaid program, and was a call for other organizations to join us in showing an open letter of support for improving coverage. You can see on the right-hand side nearly 30 organizational logos of people who have already pledged to join us in supporting improvements in coverage for lung cancer screening in Medicaid programs. You'll see, of course, the American Lung Association, the University of Texas MD Anderson Cancer Center, other partners like the American Cancer Society, Cancer Action Network, and other lung cancer patient organizations, other hospital systems, provider groups, really a broad array of different stakeholders that really shows the breadth of support for this, for improved coverage of this important service. If you are not on that, in that logo cloud right there and think that your organization would like to, also sign on to this, open letter about improving coverage of lung cancer screening in Medicaid, it is not too late. Our contact information is in the registration information for today's webinar. Please feel free to reach out to us. We'll be continuing to update that letter. We've already had some additional partners sign on in just the last couple of days, so we'll continue to update that and really hope to show a really strong showing of support for this important issue. Next, I'll highlight a few other fact sheets that really are specific about lung cancer screening coverage in Medicaid. They're also part of the toolkit. The first goes through a lot of the information that Emma went through earlier today. What exactly are the different coverage criteria for different types of insurance plans, private coverage, Medicare, Medicaid, why there are gaps in Medicaid, and why screening is so important for the Medicaid population, highlighting a couple of the top-line findings from the report that we released today, and really ending by urging Medicaid programs to support lung cancer screening in both fee-for-service and Medicaid managed care plans in their state, following evidence-based criteria and not having any barriers like prior authorization or co-pays that could be problems for patients. The second fact sheet listed here is about finding lung cancer screening coverage information. As you start to look at how you might go about improving coverage in your state, as Emma said earlier, we only looked at the fee-for-service Medicaid programs in each state. And so you might be interested to know, try and find out what Medicaid managed care organizations in your state are covering as well. This fact sheet is just sort of a starting point with some of the places you can commonly find coverage information, whether that be fee schedules, provider handbooks, and provider bulletins, a number of different Medicaid resources. The Lung Association collects data on Medicaid coverage, not just on lung cancer screening, but also on guidelines-based asthma care and tobacco cessation. And so we understand that finding Medicaid plan information can often be complicated. This guide is a great starting point, but even after many years of expertise that our staff have developed on this topic, it can still be challenging to find sometimes. And so if you're struggling and you have questions, please feel free to reach out to us, and we're happy to try and help you navigate that landscape as well. And then finally, we have a fact sheet, just a one-pager that highlights some of the top-line numbers that we think can be really helpful for educating decision makers quickly on this issue, highlighting the decreased mortality associated with lung cancer screening that both Emma, Deb, and Dr. Godoy mentioned during their presentations, talking about the cost effectiveness of lung cancer screening, which can really be an important point for state Medicaid programs in particular that are working to balance their budgets and figure out how they will cover all of the people who meet eligibility criteria in their state, as well as highlighting how important tobacco cessation is and how that can play a role in increasing the cost effectiveness of lung cancer screening programs. And then again, highlight some of the numbers that Emma mentioned earlier about, the burden of lung cancer in the Medicaid population and why, because of the increased prevalence of smoking in this population in particular, they may be at higher risk. So again, all of these fact sheets are in the toolkit, so please feel free to take a look at them and use them in your work. And then finally, the toolkit has a couple of other resources that I wanted to highlight, some specific for healthcare providers who we know can be really important players in working on coverage issues. Their voices and there are really important to be weighing in with Medicaid offices and other stakeholders who have decision-making authority over coverage policies. So we have here on our website a link to the U.S. Preventive Services Task Force recommendation that a number of our speakers have mentioned today if you want to take a closer look at that. The National Lung Cancer Screening Trial results that, again, a number of our speakers have mentioned today can be another great resource. We also have some research, very recent research that researchers at the CDC looked at, looking at lung cancer screening utilization. It's really important that not just, we certainly have work to do in improving screening rates for those who meet the high-risk criteria, but it's also important to think about whether those who don't meet the high-risk criteria established by USPSTF are getting screened and maybe exposing them to certain risks. I also want to highlight some of the great resources from the University of Texas MD Anderson Cancer Center on lung cancer screening, generally on lung cancer, their End Tobacco program, and their lung cancer moonshot initiative, which can also be really helpful background information for the different stakeholders who we hope will be using this toolkit. Of course, earlier today, Deb highlighted some of the Lung Association resources on lung cancer, which you can certainly find on our website if you go to check out the toolkit, on our Save by the Scan campaign, our different health professional and patient resources on lung cancer. So those can certainly be helpful in your work on this issue as well. So we really hope that these toolkit resources will be helpful to all of the different stakeholders who have joined us today and others who you might want to share this with. If you have questions about any of these resources, certainly we're about to do Q&A right now and would love to answer them, but always feel free to reach out to the staff at the Lung Association if you have questions, as you start digging into this a little further and want to learn more about how this toolkit and our issue brief could be helpful in your work on improving coverage of lung cancer screening. And so with that, I'm going to turn it back to Erica, and we will move into the Q&A portion.
Wonderful. Thanks so much, Hannah. And just as a reminder, if you have any questions about any part of the webinar today, whether it's Dr. Godoy's presentation, more information about the issue brief or our research and methodology around that, or the resources that are available to folks working in states to educate decision makers, please chat in your questions into the box on your screen. We got our first question. Hannah, I'll direct this to you. Just to confirm, all of the resources for this that have been covered today are available on our website, which is available to the public.
Yes, absolutely. They are all on there right now. And again, the links to both the website and the direct link to the issue brief should be in the resources tab on the webinar today. So you don't even have to type it into your web browser. You can just click right from here.
And it's also available at lung.org /lung-cancer-coverage. So that is there too. We got another question. Will Medicare reimburse a lung cancer screening if a shared decision discussion was not completed? Dr. Godoy, would you like to take that one, or is this something that we should follow up with?
I think we can follow up on this. The shared decision making must be done in all patients, and all that data goes to the registry. I'm not sure for a specific patient how that works, if they have a way to track which patients had or not the shared decision making. But as a general information, that would be available in the registry. So they would later on see which percentage of patients are being undergoing shared decision making, and so the facility can be evaluated later on. But I don't know for a specific patient coverage if they are able to check that or not.
Okay. Thank you. That's very helpful, and that's something that we can also look into and follow up a little bit more online. One of the questions that we got is, can you comment on how to make education about lung cancer screening more available and more widespread? I understand that only 4% of eligible people are getting screened. Dr. Godoy, I would certainly welcome your answer, and then we are happy to answer that from the American Lung Association's perspective as well.
I think the education can start from each particular institution. So in our institution, we have been visiting different clinics, and because lung cancer screening is still relatively new if we compare to breast screening and other things, so the providers are still not aware of details on eligibility criteria and all those things. So it's important for each program to start in their own community teaching, and then also to have programs that are in the national level, so that those resources are available to help the teaching. In our institution, for example, we are also working and collaborating to develop tools for shared decision making, and to help to have better illustrations and facilitate communication with the patients and the providers, to have access on those tools in iPads, and all we can do to facilitate the communication. So I think there are two levels of education that need to be emphasized.
And we agree, and one of the reasons that the American Lung Association partnered with the Ad Council for our Save by the Scan campaign was really to raise the profile of the importance of people who are at high risk talking to their doctor about being scanned for lung cancer. And so we certainly also hope that this partnership between the American Lung Association and the University of Texas and the MD Anderson Cancer Center can also help raise the visibility of this, as well as the issue brief that we released earlier today. We have some other questions that have come in. My state covers lung cancer screening through Medicaid, but does not have clear eligibility guidelines. Do you have any tools or materials for me to use to educate my state's Medicaid program about the guidelines? Hannah, do you want to take this one?
Sure. So I would definitely encourage you to start with the USPSTF recommendation that's in our toolkit for healthcare providers. They have a couple of good resources on that website that can give you a quick overview of their recommendation and the evidence that they use to develop that. And then I also think that our fact sheet on access to lung cancer screening coverage can be a really great starting point for you to look over the different types of criteria and you know, start a conversation with the state Medicaid program about why it would make sense for to line up the eligibility criteria with those guidelines.
Thank you, Hannah. I think we've gotten a few very technical questions with regard to reimbursement for coverage, which is a difficult issue across the board, and that really goes beyond the scope of this project. And so I just want to flag that we have certainly heard those questions, but will not be able to answer them on today's webinar. We had another question. Will state-specific information be available? Hannah?
Sure. So we absolutely have state-specific information available in the issue brief. You can see whether or not your fee-for-service program covers screening, what the eligibility criteria are if they do, and whether or not they require prior authorization if they do cover screening. So that's a great starting point. And then I think, you know, certainly the resources on our website, you know, are general and can be used in any state, but I really think that they're designed to talk about these issues in a way that they could start a conversation with a state Medicaid office or other decision makers. So I think you have both the information, the coverage information to use as a starting point, but then I think the different tools in the fact sheets and materials section can really be customized for any state.
Wonderful. Another question, are you actively pursuing legislation, and I'm going to take that for the American Lung Association, is the American Lung Association actively pursuing legislation in states that lack coverage?
So I can take that one. This is Hannah. So you know, that's really not the purpose of today's webinar, to talk about, you know, some of those efforts. I think one of the things that I will just highlight is that, you know, in many states, it hasn't taken legislation to change these coverage policies. And, you know, many states did it by themselves after either the USPSTF recommendation or the Medicare recommendation came out. And so, you know, they just did them on their own. They didn't really need separate legislative authority. So certainly in states where there are gaps in coverage, you know, it would vary on what tactics you would need to use, but we really think that the different resources that we're highlighting today are really just meant to be educational materials that you can sort of use as a starting point if you think about how you might want to pursue this in your state.
Wonderful. And I would just add to that that not every state needs to do this through legislative methods oftentimes, and one of the things that we want to really have these data available is to encourage conversations to that extent. We got another question about the methodology and the way by which the American Lung Association did this research. Is that something, Hannah, that you can also to answer?
Sure. So the American Lung Association in December reached out to every state Medicaid fee-for-service program and asked them a number of questions about their coverage policies. One thing to note is that the American Lung Association requires publicly available documentation when we're looking for information about screening. That's not just true for this project, but across all of our different efforts on Medicaid coverage for different, you know, lung disease issues. So, you know, it wasn't enough for a state Medicaid program to say, you know, just yes, we cover this. We needed some kind of documentation, whether that be a fee schedule that showed reimbursement for the CPT codes. That are a very technical thing for some of the folks on the, you know, but if you're not familiar with this area, but are just simply a reimbursement code that providers can use to be reimbursed for this service. We also, in some states, we were able to review bulletins that have been sent out to providers or pieces of, you know, regulatory language if a state had decided to cover the service through that mechanism. So looked at a wide different range of coverage policies, and then that is the information that we use to compile the issue brief for today.
Wonderful. One of the questions that we received, I think, highlights a challenge. And so, again, while we can't necessarily comment on reimbursement rates, I do think it's worth sharing this challenge. This is from a physician at a doctor's in a health system. The significant reduction in Medicare for reimbursement for LDCD and shared decision making has had a dramatic impact on departments and hospitals willing to perform lung cancer screening, and likely will be encountered with the Medicaid population as well. What is being done to address the reduction in reimbursement? And I know that a number of our organizations are working on those issues and the challenges and the frustrations associated with that, because certainly that does impact access issues across the board for patients who are at high risk. And so I do think that I did want to flag that and just mention that as well. One of the questions that was asked, and I'm going to kind of, to paraphrase this for Dr. Godoy, do you generally have a problem with your patients not having coverage for follow-up scans? Is that something that you encounter if you, when patients, not in the screening phase, but in the follow-up or in the diagnostic phase, are coverage for those scans sometimes an issue as well?
We have not had that problem in our general population. Most patients have private insurance, and we didn't have that issue. We had some concerns about that in our research area for patients that are in clinical trials in our institution. Sometimes they do not have private insurance, and the follow-up might not be covered by the trials. In that case, we had to work to make sure that they have coverage from healthcare, and but we were able to achieve that. We have not had issues with that.
Thank you. That's helpful to know. We got a question here. What is the difference between fee-for-service Medicaid and managed care, and how does that affect Medicaid coverage of lung cancer screening? Hannah, do you mind mentioning that again?
Sure. And so Emma talked about this briefly in her presentation, but you know, Medicaid fee-for-service is sort of what I think most people think about when they think about, you know, standard traditional Medicaid, where, you know, if an individual qualifies for Medicaid in that state, they're covered by the state. If the patient goes to see a provider, the state reimburses that provider directly. That's the sort of general model. On the Medicaid managed care side, the state pays a private health insurance plan, a certain, usually a per member per month fee to manage the healthcare needs of the patients that they cover. And so the managed care plan might be setting the policies around something like lung cancer screening. And so the reason that we've talked about that earlier in our presentation today, again, is that we looked at the Medicaid fee-for-service policies in each state as part of this analysis, but not the individual managed care organizations. And in some states, a state only has the fee-for-service program. In other states, they may have upwards of 20 different managed care plans in the state serving Medicaid enrollees. So there really is a lot of variability there.
The next question is for Dr. Godoy. Dr. Godoy, are there evidence-based approaches recommended for public education on lung cancer screening? For example, is there research on effectiveness on one-on-one education versus group education?
There's a lot of research on how to perform and how to improve shared decision making. I'm not aware of research on effectiveness on one-on-one versus public education, but some of the work we're doing is to see different ways to improve education, as I mentioned before, using materials that are given to patients either ahead before the visit so that they can prepare for the discussion, or using more illustrative and more tools that they can use on iPad and things like that. And that has been demonstrated to improve their understanding about risks and benefits. And that's some research that has been led by Dr. Lowenstein and Dr. Volk, and is soon to be published. So there is research on how to improve shared decision making for sure.
Okay, wonderful. Another question for Dr. Godoy. Can you please address incorporating cessation services into lung cancer screening? Do we have data on the quit rate within lung cancer screening programs?
That's an excellent point. And some of the concerns that were raised before were if we're doing lung cancer screening, if patients would feel safe that they can continue smoking because we are screening them and things like that. And but the data has shown that that doesn't happen, and it actually can improve smoking cessation by patient participation and understanding their change. We have the opportunity sometimes to sit with the patients and show them the change related to smoking, emphysema, coronary artery calcification. All of these things can emphasize for the patients the need for smoking cessation. And so it's a wonderful opportunity to combine lung cancer screening and smoking cessation, and that's the way we should pursue this.
Thank you. Another question I think I'm going to throw to Hannah. I have seen some Medicaid patients in our state having reached a spend down amount, and this has prevented them from completing the CT lung cancer screening exam. Any thoughts on this issue?
I would just say I think that, sorry, can you repeat that question, Erica?
Sure. Some Medicaid patients in our state have reached a spend down amount, and this has prevented them from completing the CT lung cancer screening exam. Any thoughts about this issue?
So I'm not familiar with that specific policy, but let me just say that there are, every state Medicaid program is different. While it's a federal program, it is administered by the states, and so coverage, certainly coverage policies can vary from state to state, but also, the different, requirements about cost sharing for patients can vary from state to state as well. Some states, for example, might have an overall limit on the number of prescriptions a patient can have, which can certainly be an issue if you're trying to take tobacco cessation medications. There are a lot of different issues, and the in terms of coverage, patients may have to, in some states, have to pay co-pays for services. They may have a premium that they have to pay for their Medicaid coverage. So there can definitely be a number of financial barriers for patients that can be an issue when it comes to lung cancer screening and just accessing Medicaid services more broadly.
When smokers access their state quit lines, is there any education about lung cancer screening shared? This is Erica, and I'm going to just kind of give a quick answer to that. There are different quit lines for most states. I will know that the American Lung Association does have a quit line. We run the Illinois Department of Health Smoking Cessation quit line. And then we also have our own lung health helpline at 1-800-LUNG-USA. Oftentimes, I think this is something that would have to be specifically addressed when people call in, and I'm not aware of any protocols that immediately kick people into being flagged for eligibility for this. But that's a really good question, and I'm happy to flag that for our tobacco cessation policy and program experts as well as our helpline, because I think that is a very interesting opportunity for integration. I will kick this one to see if either Dr. Godoy or Hannah would like to answer this. Once screened and if lung cancer is found, are there any known disparities in treatment options for Medicaid recipients? It's a little outside the scope of this project, but generally that does speak to the access to care in general for lung cancer recipients.
It would, it would certainly depend on the, as Erica mentioned, it's a little outside the scope of this project. It would depend on the state and what exact, services that they cover. But I would think, in general, that if a patient was, found to have, evidence of lung cancer, that, certainly, again, there could be barriers that could make it more difficult for them to access, follow-up services, but those should be covered by the state.
We are running up towards the end of our time on this call, so would love to see, just scrolling to see if we missed any questions, and really appreciate the opportunity to talk with everyone today. And we are most appreciative of Dr. Godoy's time today. And really appreciate her presentation. I think it's really helpful for the policy people on this call to hear from her about this process and from the medical perspective. And I hope that it was also helpful for the number of medical professionals on this call to hear about the policy aspect of this, and really hope that as a result of this project we can further integrate across the board. And I do have one final note from the Lung Association's helpline, which does go over screening eligibility with all callers enrolled in quitline services, and to let them know if they are eligible or not. And if they are, then and want more information, then the Lung Association helplines provides that. So that's really great to hear, and hopefully something that is being provided more broadly, but certainly from the Lung Association's helpline, which is available at 1-800-LUNG-USA. And with that, I'm going to thank you all for your time. Again, a special thanks to Dr. Godoy, and all of the resources are available that you heard today, both through the resources button on your platform or at lung.org/lung-care-coverage. So thank you so much, and we appreciate your time today.
Thank you very much. This concludes today's webcast. You may now disconnect.